So, session 5 of Rhythm Interventions Online. The final session is going to be talking about some advances in pacing and pacing technologies. We're going to first move on to Aldo Rinaldi, who's going to talk to us about leadless technologies for CRT and physiologic pacing.
Thank you very much, Richard, for that kind invitation. It's my great privilege to talk about leadless technologies for cardiac resynchronization and for physiological pacing. These are my disclosures in relation to this talk. Now, endocardial CRT, there may be some advantages to adopting an approach where we pace from within the left ventricular endocardium, certainly in terms of increased access to sites, which may lead to a greater implant success. We may be able to avoid phrenic nerve stimulation. And by activating the ventricle from the endocardium, we may get a more physiological activation, and we may be able to access the His-Purkinje network, resulting in better hemodynamic and long-term effects in terms of resynchronization for our patients. Traditionally, endocardial pacing has been delivered using an atrial transeptal approach, and there have been various techniques that have been developed. However, there are certain drawbacks to this approach. Firstly, the technical difficulty in performing it, but also there are issues in terms of a lead across the mitral valve interfering with the mitral apparatus. But probably the Achilles heel of this technique is having a lead in the left ventricle and the thromboembolic risks associated with that. So as a result, lead-based pacing within the left ventricle has not really been adopted in a major fashion. This has led to the development of leadless endocardial pacing. At the moment, there is one commercially available system, the WISE CRT system, that is capable of delivering left ventricular endocardial pacing. As you can see in this diagram, it requires a co-implant, which is either a ICD or CRT. And then the device then has an electrode, which is the receiver electrode, which is placed within the left ventricular endocardium. And this is approximately the size of a grain of rice. This then receives ultrasound from a phased array transmitter, which is placed within an intercostal space and delivers energy from a battery. And in conjunction with the co-implant, then you're able to deliver synchronous atrial biventricular pacing with the system. In terms of the implantation of the system, you require a pre-implantation assessment to ensure there's an adequate window in terms of being able to deliver the ultrasound energy to the electrode that's going to be placed within the heart. And this is performed with ultrasound so that we can assess where is the optimal intercostal space to place the electrode. In terms of implantation of the receiver electrode, this is usually placed via a retrograde aortic approach, which requires 12 French femoral arterial access. And then the guide sheath is delivered to the left ventricular endocardium. And through this, the electrode then is placed or anchored into the left ventricular endocardial wall. And once it is anchored securely, it is then released. As you can see in this image, approximately after 6 weeks, the device becomes endothelialized. So this does not have the risks of thromboembolism in the long term in these patients. The data surrounding the use of this form of technology. The first study really which showed the benefit of this technology was the SELECT-LV study published by Vivek Reddy et al. And this was a feasibility study in 35 patients. The primary endpoint of this study was the ability to deliver biventricular pacing on a surface ECG at 1 month post-implantation. In terms of the implantation demographics, these were mainly patients who either failed to receive CRT or were felt to be high-risk upgrades. As you can see in this study, the success rate was over 97% in terms of implantation, and 33 out of the 34 patients were able to receive CRT at 1 month. This was associated with significant improvements in both ejection fraction and in terms of remodeling. But as you can see, there was a complication rate associated with this, both in terms of vascular access, complications, risk of tamponade, and longer-term risks with the device. Moving on from this, further information comes from the real-world experience of this system. This is the European multi-center registry of the WISE CRT system. And this includes, in this published algorithm, 90 patients that received the device throughout Europe. Again, a similar population that was implanted, with a minority of patients who were CRT non-responders. Again, we can see a very high procedural implant success rate, but as you can see, similar rates of complications in terms of arterial access issues. If we compare the Select LV with the registry, both in terms of implant success, we see a very high rate of implantation, both in the Select LV, but also in the registry. And as you can see, there is a rate of both acute and more chronic complications. But if anything, these were lower in the registry in the real-world use of this device. And if the device is able to be implanted and deliver biventricular pacing, you can see very impressive results in terms of both clinical response and also echocardiographic response, with good rates of remodeling in these patients. As we mentioned, one of the drawbacks of this approach is the vascular access issues in terms of the femoral arterial axis, and this has led to the development of the transeptal approach. This was the first patient that we used this on in London in 2017, and in this case, rather than go retrograde arterially, and we placed the guide sheath across the mitral valve apparatus and implanted it here near the papillary muscle and released it. This technique, of course, will remove the arterial access complications. And in the same patient here, you see a TOE image here of the guide catheter going across the mitral valve. And you see then excellent electrical resynchronization, both pre and post YCRT, with a significant narrowing of the QRS in this patient. The SOLVE-CRT study is an FDA study and a randomized study of over 300 patients to assess the benefit of this. This study has already recruited over 100 patients in whom will all be implanted with the device, and then 50% of them will be randomized to have the device turned on with the primary endpoint at 6 months. Due to the COVID pandemic, however, there have been significant problems in terms of recruitment. And as a result of this, the study has been changed into version 2, which is now FDA approved, whereby this will be a single-arm study assessing patients in terms of both safety and also the efficacy endpoints in terms of remodeling and improvement in ejection fraction. Is it possible to use this technology in addition to completely? This is a patient here that's received as a co-implant a micro device here, which is able then to deliver biventricular pacing in addition to the WISE CRT device. And this patient also has, in conjunction with this, a subcutaneous ICD. So it is now capable to deliver completely leadless CRT-D systems in these patients. What about the potential for physiological pacing using leadless technologies? I'll just briefly talk you through this slide. This is a patient that is undergoing different forms of acute pacing. We can see the x-rays on the left, and we're able to deliver both standard CRT, his bundle, left bundle pacing, and also left ventricular endocardial pacing. The patient has a cardio insight jacket, and we can see the different activation maps in terms of the different pacing protocols. You can see here in the top left, intrinsic left bundle branch bulk with late activation of the lateral wall and long activation times in the left ventricle, with similar activation with right ventricular pacing to the right of that. And then we can see in the middle panels with conventional CRT delivered from the coronary sinus, pre-excitation of the lateral wall and significant resynchronization of the left ventricle, but a much greater degree of resynchronization of endocardial CRT. If we look at the bottom panel with His bundle, and importantly, you see very rapid activation of the right ventricle. And on the right panel next to that, you see left bundle branch pacing, again with rapid activation of the left ventricle. But you can see the right ventricle is somewhat desynchronized in relation to His bundle pacing. So certainly there does seem to be benefit in achieving physiological pacing. The desynchronization with left bundle pacing may be able to be overcome with altering your AV delay. This is a modeling study where this has been performed. By varying the AV delay and allowing fusion with left bundle pacing, you're actually able to get very good resynchronization of both the left and right ventricles. Can we perform leadless endocardial pacing with standard devices such as the Micra or the Nanostem? Well, probably unlikely at this stage. This is a modeling has been made out of computer-generated system using CT guidance. And essentially what has been found when we do this is if you place a Micro or Nanostem within the left ventricle, it's probably going to collide with other structures within the left ventricle, which will probably mean that we can't actually use this for physiological pacing. But there may be a potential to use devices such as the WISE implant. So this is in a pig model. This is a pig model with a transeptal approach where you can see the sheath is being delivered here. And then you can see on the left-hand panel, the device actually placed within the left bundle. On the right panel, you can see, again, the transeptal approach is in Australia, where the device is being taken towards the septum. So there is a potential to perform physiological pacing from the left bundle area. And again, this is one of our patients from London where we did this whilst implanting the WISE CRT device. If you look at the ECGs, both of intrinsic RV pacing, you see significant narrowing with left ventricular endocardial pacing from the lateral wall. But in the bottom panel, you see left bundle pacing from the left side of the septum with significant narrowing of the QRS with physiological pacing. And this is associated with very good hemodynamic response in this patient. So it may well be that we can target the left bundle area using leadless technologies in the future. So I'll summarize at that point. I think leadless left ventricular endocardial pacing is an option and can currently be used now for patients who are non-responders or unable to receive CRT. Site selection is going to be important, especially avoiding scar. There are some limitations in terms of the co-implant, the battery longevity, and the implant complications, but I think these will decrease over time with operator experience. And I think the ability to synchronously pace multiple chambers in the future and also to potentially perform conduction system pacing without the drawbacks of leads within the ventricles is going to be something for the future. And I think the future is going to be leadless. Thank you very much for your attention.
Great, lovely talk. Thanks, Aldo. We'll move straight on to Dr. Vijay Araman from Pennsylvania, who's going to talk to us about his pacing tips and tricks. And I think that it's fair to say that he's one of the world's leading authorities on this technique.
Thank you, Professor Schilling, for inviting me to present my topic, His bundle pacing tips and tricks. If you look at the His bundle pacing tools, early on we had a deflectable sheath without a septal curve, and the 3830 lead was the mainstay of His bundle pacing. Caused some challenges. However, the availability of C315 His sheath made it a lot easier to perform His bundle pacing. The recent introduction of the C304 His sheath, which is combining the deflectable as well as the septal curve, that has made His bundle pacing a lot more easier at this point. And other manufacturers also come up with sheaths where you can use this preformed sheath to deliver traditional active fixation leads. And so far, no large series have been published, but it's been shown to be feasible to perform this procedure. And there's a deflectable Hispro sheath from Abbott, which is also available to implant traditional active fixation leads. And one of the important things, at least in our practice, is to make things more comfortable because the lead is somewhat longer, have a Mayo stand to support, and also have the full setup to display a 12-lead ECG, both the active and review fluoroscopy screen, pacing system analyzer, and a review screen of the 12-lead to make sure that you can confirm conduction system pacing. That's very critical in terms of successful His bundle pacing lead implantation. So here we predominantly use unipolar mapping during His bundle pacing. The lead tip is just outside the sheath, and you can make this unipolar connection and have all this unipolar electrogram to demonstrate that you can achieve excellent electrogram recording from just a pacing lead. Another important thing is to be able to simultaneously display both using the PSA and the EP recording system. So we have these connections. And secondly, we also need to ensure that you can record injury current potentials in the His bundle. And as you can see in this example, the middle panel has a high-pass filter that's been changed to 0.5 hertz that allows demonstration of His bundle injury current after implantation of the lead at the His bundle location. And then finally, you demonstrate selective His bundle pacing in this case. So it's easy to understand that His bundle pacing is feasible in AV nodal block, but His bundle pacing is also possible in patients with infranodal heart block, as you can see in this example. I'm sorry, some of my slides are overlapped here. But you can get complete correction of underlying bundle branch block with His Purkinje pacing. How do I map in the setting of intraHisian block? So one of the things is to use a landmark. Here we have a patient with TAVR, and usually the lower end of the TAVR struts is the site where the His bundle is being compressed from the left side. And the right panel shows electrogram that has 2-to-1 HV block in this patient. Pacing at this site results in selective capture of the distal His, but may not be ideal for final positioning. So we mapped and moved the lead a little bit further. And as you can see, the lead is only about 3 to 4 millimeter distal. And now you have the distal His potentials. And during the lead implantation, we caused a right bundle branch block that was transient, but however, pacing from this side, you can see complete correction of the underlying right bundle branch block and AV block. Important thing to assess is during mapping, ensure that you have adequate sensing. Because you're at the AV analyst, you can see atrial signals, His signal, and ventricular signal. So the threshold at this site was excellent, but may not be acceptable. So you have to move the lead slightly further distally, and where the R waves are much bigger, the atrial signals are smaller, so you can use this part to achieve a good His bundle pacing. In a C3115 His sheath, the hub of the catheter is pointing at 6 o'clock. That is the traditional home position. And if you want to advance the sheath more towards the ventricle, slightly rotate the sheath clockwise and advance the lead and the sheath. In a deflectable sheath, that orientation is slightly different. It's at 9 o'clock location, and similar clockwise rotation will get you across the valve towards the ventricle. And in this, can we play the video here? Video, okay, there you go. So as we are moving the lead, you can see there's a larger atrial signal, And I tend to slightly clock the sheath and advance the lead further. Now we've identified the His signal. And once you identify the His signal, at this point, we gently advance the lead. And because it's an exposed screw, it fixes to the septal wall. And once you confirm that there is His electrogram, then you can passively fix the lead at this point with 1 or 2 rotations. And that should fix the lead. And then confirm it by, can you go back to the, can you play the video, please? Okay, there you go. So once the lead is fixed with rapid rotations, then the lead positioning is confirmed, and then check unipolar and bipolar electrogram at this location. And here you can see what we were talking about earlier. Following the lead fixation, you can see the His signal is somewhat wider, but on the top panel, you can see a significant His bundle current of injury. And that is a sign that would suggest that your thresholds are going to be excellent. Even acutely, the thresholds may be higher, but then these thresholds will significantly get bettered by the end of the case. And assessment of His bundle capture is critical for successful His bundle pacing. And here during threshold testing, you can see non-selective His bundle pacing. And as you come down on the output, there is a widening of the QRS duration, and the QRS morphology is significantly different, suggesting RV capture. You can see the stim to peak LV activation time has increased from 85 to 125 milliseconds. And the retrograde atrial activation time is also significantly prolonged, suggesting loss of His capture. So this would be our His bundle capture threshold at this point. So in this panel, a few minutes later, as the His bundle current of injury came down, you can see there's transition from non-selective to selective His bundle pacing. This happened around 1.5 volts. And then the His capture threshold was 0.5 volts at 0.5 milliseconds. Here you see the change from non-selective to selective. Important thing is the QRS morphology is clear, going from pre-excited beat to a completely normal QRS with an isoelectric segment from stimulus to beginning of the QRS. And the QRS duration is similar to the native QRS. An important way to identify selective His bundle capture is at the pacing artifact, you can see that separation of the local electrogram. When there is RV myocardial capture, that's pulled into the pacing artifact. So this clearly confirms non-selective to selective capture. And in difficult cases, sometimes you can use low fluoroscopy, but use a 3D mapping system to help successfully implant the His bundle pacing lead. We don't use it on a routine basis. In this case, you can see underlying left bundle branch block. Using precision mapping, we're able to document all the sites with His bundle locations, and the sites, the green dots, were where left bundle branch block correction was achieved, and subsequently implanting the lead in successful left bundle branch correction with His bundle pacing was achieved in this patient. Again, occasionally we use His bundle pacing 3D mapping in complex congenital heart disease, as in this patient with corrected transposition. And you can see the 3D reconstructed CT in this patient documented all the His bundle regions. And clearly you have excellent His electrograms for the final implant site with evidence for non-selective His bundle capture in this patient. So looking at clinical outcomes, in our experience, we've been attempting His bundle pacing for the longest time, more than 10 years now. And in our series of 2 hospitals, one hospital primarily RV pacing, and the second hospital was all His bundle pacing, with 332 pacemaker naive patients, first-time implant, we were successful in 92%, including all patients with underlying AV block, infranodal AV block. And RV septal pacing was performed 8% due to failure to implant, primarily in infranodal AV block patients. And then primarily RV pacing performed in all of the patients in the second hospital. During a mean follow-up of 2 years, we're looking at the primary endpoint of death, heart failure hospitalization, or upgrade to biventricular pacing was significantly reduced in all patients, and there was a 29% relative risk reduction in the primary endpoint between the two groups. And all of this difference came primarily from those patients who had greater than 20% ventricular pacing. And when we look at all-cause mortality, there was a trend towards improvement in mortality in those patients with hisbundle pacing, and this did not reach statistical significance in this group. So in our center, this is our current protocol, given the fact that we can achieve left bundle branch pacing and reach the conduction system. So anybody who needs an indication for RV pacing lead, if they have normal His-Purkinje conduction and right bundle branch block, we primarily attempt His-bundle pacing and try to get threshold less than 1.5 volt. If not, then we move on to left bundle branch pacing. If the patient has underlying HV block or left bundle branch block, we resort to left bundle branch pacing as a first-line therapy. If unsuccessful, and if the patient needs LV dysfunction and heart failure management, then biventricular pacing, if not RV septal pacing in those patients. And thank you very much.
Great, two wonderful talks. We've got 2 minutes left, so maybe I can ask you each one brief question. Aldo, first of all, a question from the audience. How big is your practice, and what percentage of these patients have leadless LV pacing? And what do you need to do to get set up and justify doing this procedure?
Yeah, so it's a minority of patients undergoing CRT. These are patients, Richard, that have either had failed implants or high-risk patients that you may consider an extraction if there's venous obstruction, or non-responders. So I think in terms of the absolute percentage, we're talking relatively small numbers, but I think this will increase in the future. We know approximately 30% of patients who receive standard epicardial CRT will be classed as non-responders. So there is a large group of patients that may benefit significantly from this. In terms of setting up at the moment, I think depends on your geographical location. In the US, that's part of the FDA study. Most implants have been performed either as part of a study or within a registry.
Super. And Dr. Vijayaraman, what are the things, I mean, it sounds like you're making a very strong case that as many people should have His-bundle pacing as possible. What are the things that need to happen to make this easier and make it a mainstream procedure?
So while His-bundle pacing has been fairly successful in a large number of patients, there's still challenges. One of the things that we still struggle is that there is about 10 to 15% of patients that have threshold increases, which is unpredictable sometimes. So that's something that we need to understand why it happens, and we need to fix that. It might be related to somewhat superficial implantation in a fibrous membranous septal region, and also lack of adequate steroid. So once that is fixed, I think mapping has become a lot easier with a deflectable sheath. An implantation for an electrophysiologist in His-bundle pacing would be a lot more easier. How we get your general cardiologist, non-electrophysiologist to implant His-bundle pacing is the next challenge.
Well, I'd just like to thank you both for giving us a fantastic finale to a great meeting.
Thank you for
Wow, what an amazing 3 days. I hope you've enjoyed it and got as much out of it as I have. I would really like to thank the faculty and particularly the institutions that hosted our live cases in what I think we'll all agree is incredibly difficult circumstances that we live in healthcare in the world today. I also want to thank the 3,000 or more than 3,000 electrophysiologists that joined us in the audience and the amazing feedback that you've given us. I also want to thank Radcliffe Medical and their amazing AV team. I think we'll all agree that the production values and this meeting have been incredible, and they're only going to get better. Hopefully in 20 years' time, you'll all be able to talk to your fellows and say, I was at the first Rio meeting in 2020, because this is not going to be the last. Your feedback's really important. We're going to improve the meeting, and I really hope to see you again next year. If I wasn't on call now, I'd be going off to have my post-conference beer, but obviously that's not going to be possible. I hope you all have a safe journey home. Oh, hang on, you are already at home. Thank you very much for joining us, and hope to see you again next year.